So good evening everybody to OrthoTV, and we have a very innovative topic today as well as a very focused panel. On panel we have Dr. Salim Patel and myself Dr. Ashok Shyam. To introduce the topic and the panelist, I invite the moderator today, Dr. Salim Patel. Over to you, Salim.
Yeah, thank you, Dr. Ashok. A very good evening to all our respected delegates on OrthoTV. Today we are continuing with our trauma series, and before I talk about the topic, I would first like to introduce our speaker. He's none other than a senior orthopedic surgeon from Palakkad. It's Dr. Anil Kumar V. Dr. Anil Kumar V is a senior consultant orthopedic surgeon at the Semalk Hospital in Ottapalam in Kerala. He has been practicing for the past 32 years. He's been a member of the esteemed organizations in orthopedics like the IOA, then the American Academy of Orthopedic Surgery, APOA, along with the Kerala Orthopedic Association and the Orthopedic Association of South Indian States. Dr. Anil Kumar sir has presented vast number of papers all across the world, including the topic for today, which is his own novel method of close reduction and painting of intra-articular distal radius fractures, for which sir has designed his own K-wire jig, which he uses in fixing such complex type of wrist fractures. So I would now hand over the session to Dr. Anil Kumar sir to start the proceedings. Over to you, sir.
Good evening. I am Dr. Anil Kumar, working as an orthopedic surgeon at the Semalk Hospital, Ottapalam of Kerala. It's a charitable trust hospital, and most of the people coming are poor parties, poor patients with economic constraints. So, about 25 years back, I started my innovative work to give a low-cost surgical treatment for the poor people within their economic constraints. Hence, I started this close reduction and percutaneous peeling technique for the fractures. I'm not only doing this for this fracture distal of radius. This aim of my innovative treatment was to provide a simple but effective, low-cost, patient-friendly treatment for fractures with early return to their livelihood. It includes fracture around the wrist and hand, fracture forearm, fracture around the elbow, fracture proximal humerus, fractures around the ankle, fractures of the foot, and fractures around the knee. First, I show some slides of all these for a brief introduction. This is the fracture around the shoulder. For a fracture, this is a close reduction and percutaneous peeling for the proximal humerus. This is a fracture around the elbow. This is a 77-year-old lady. The close reduction percutaneous peeling for supracondylar, intercondylar fracture. Then fracture around the elbow. This is a 1.5-year-old child. The proximal third humerus, distal third humerus, done by close reduction and percutaneous peeling. This is a fracture around the elbow, the type 3, and this is also done with close reduction and percutaneous peeling. This is fracture lower third forearm, fracture both bones. I have done this close reduction and percutaneous peeling for this fracture. This is another type. Here, close reduction percutaneous peeling for radius and also for the ulna, as it is a small bone. This is in another method we can introduce that into intramedullary fixation from the distal ends. This is a fracture around the wrist. This is the main topic that I am going to present today. Around the hands, it's a bayonet fracture, you can see, and also fracture metacarpal, and also fracture phalanx. All these can be fixed with a close reduction and percutaneous peeling. These are the fractures around the foot. This fracture, metatarsal injuries, we can easily manage these fractures. You can see this fifth metatarsal is displaced more than 1 centimeter laterally, which is reduced and fixed with this close reduction and percutaneous pinning, and very good results also. This is another case. This first metatarsal is accommodated and fracture dislocation also there, treated by same method. And this is fracture around the ankle. This is a posterior malleolar fracture, and also this lower third fibular fracture is also there and fixed with this the close reduction percutaneous pinning, both posterior, medial, and also these fibular fractures. This is a fracture around another angle. This is a trimalleolar fracture, and which is also fixed with the same technique. This is a fracture lower third leg, which can be fixed in the severely accommodated fractures. We can fix it alternative to other methods. And this is the third X-ray shows the fracture, healed fracture X-ray after 4 months. This is a fracture upper third leg. Let's say the patient came after 3 days from another hospital with the local condition for doing the surgery was not suitable at that time. And they advised him to return to the hospital after 2 weeks. But that patient had severe pain and severe edema. So I have admitted him. And on the second day, I have done close reduction and percutaneous pinning, as well as a cannulated cancellous screw for transverse things. You can see that the result also how is the outcome of that surgery. These are my achievements, presentations of various national and international conferences. Everything was said by Dr. Salim Patel. Today, I'm going to my topic, the fracture of the distal end of the radius. The fracture distal end of radius is one of the most common fractures of the upper limb, of which approximately 50% are intra-articular fractures. Today, I am presenting about the intra-articular fractures alone. There are various classification systems depending upon the type and mechanism of the fractures. I'm not going to the details. Unlike the lower energy extra-articular fractures, intra-articular fracture of the distal radius represent a complex injury that is associated with a considerable morbidity. Open reduction in internal fixation generally requires extensive soft tissue dissection and have been associated with a higher complication rate even in fragment-specific fixation. CMR and POP end up in malunion and intra-articular stepping. In external fixation technique also, there are inevitable complications. Arthroscopic assisted surgeries have a good role. So generally, more than one technique is used to treat the intra-articular fracture distal end of radius. Here I am presenting my innovative technique of close reduction and percutaneous pinning for all intra-articular fractures. Regarding the evolution of the percutaneous pinning, Lambert in 1908 described the placement of a single pin into the radial styloid. Later, the technique was modified by Steen and Cox in 1975 with additional pins. Ollertat, Jacob, and Mortier in 1976 also the same technique. And Capanchi modified the technique in 1976 with a new concept of intrafocal pinning, with a later modification in 1986 with addition of third pin. These techniques were not applicable to the intra-articular fractures as they are not stable fixation for this intra-articular fractures. The role of percutaneous pinning in intra-articular fracture distal end of radius is that presently the role of percutaneous pinning for intra-articular fracture distal end of radius is limited as an add-on procedure to the other methods like ORIF or external fixation. Regarding my technique of close reduction, there are 4 steps. That is a manual distraction, compression, milking, and repositioning of the distal radial nerve joint. Anesthesia is regional, and the distraction is done manually by the traction and counter traction with a first assistant, and the hand is transferred to the second assistant in 2 stages without losing that distraction. Then the second step is a compression of the fracture fragment. That's a componented fracture fragment are compressed with the thumb and index finger from the proximal to distal direction towards the radiocarpal joint. And a repositioning of the distal radial nerve joint is the final step. You can see the video. This is a manual traction with the surgeon and the first assistant. The index and the middle finger is handed over the first, and the surgeon is taking his hand to the capture the medial four-metacarpal. After that, the thumb is also transferred. This is a compression technique. And also, that's the third stage, that's the milking with both the thumb and both the index finger in the volar side. That's the main step. In the ligamentotaxis position, this milking is the main technique, so that it can be, all the fracture fragments can be positioned into its original condition. And after clinical judgment, proceeds for the pinning without imaging, because we cannot lose any time, because if the surgeon's or if the assistant's hand is going to be fatigued, then all the reduction will be lost. So without checking for this imaging, we will directly go for pinning. The pinning has three steps: the creation of the first triangle, creation of a second triangle, and the placing of the end of the cavers in the subcutaneous plane. You can see the first triangle is created by first caver from the radial styloid towards the proximal fragment at an angle 40 to 60 degrees. The second wire from the proximal fragment towards the lunate fossa. That is also the same angle. And the third wire from the ulnar head towards the radial styloid through the radial nerve joints. You can see the orientation of the wires so that the first triangle is completed. The position is checked with the CR, and the length of the wire is cut short so that we can reduce the we can create the second triangle. The creation of the second triangle is also in the same direction, but it's in a slightly different plane. That is from the radial styloid towards the proximal fragment. That's the fourth wire. That's the fifth wire from the proximal fragment towards the lunate fossa in little bit angle difference and also in plane difference. And also the sixth wire from the ulnar head towards the radial styloid, which is also in different plane. This position is also, you can see the orientation, and this position is also checked with the C-arm, and if it is okay, the protruding ends of the cavers are removed. And the third step is the wires are bent at 90 degrees with a caver bender, you can see. The leverage will be given by pressing towards the bone, deep pressure through the skin and subcutaneous tissue, so that it will not move. The protruding ends are cut close to the subcutaneous tissue, that is by giving a pressure through with this caver cutter. This is a carved cutter so that we can give the pressure to the skin. After that, we can pull the skin with a thumb forceps so that nothing will be seen outside, and which will not, the outside, usually the end of this caver will interfere with the wrist joint movement, but here it is not interfering with this. If there is a severe combination, we are giving a POP slab, and if it is a little bit a small combination, we can give this wrist splint. These are the orientation. The first picture, first triangle is created. Second is the second caver, and you can see the orientation of the wire in the plane. That's the plane. The third picture shows the different planes for the fixation of the two triangles. Regarding the postoperative, wrist splint of POP given for 4 weeks. The patient can remove the splint from the second postoperative day onwards. In the OT itself, the patient is moving the limb. The second day, the patient can remove the splint and he can do the exercise. The patient from the second day onwards, the patient can do some form of personal work, including writing or buttoning or dressing or something like that. Some small work can be done from the second postoperative day onwards. And as the time goes on, he can do more and more. And the splint will be removed at 3 weeks or 4 weeks, depending upon the combination. The caver is removed at 6 weeks. That is, after 3 weeks or 4 weeks, the patient is permitted to move the wrist joint, the anteroposterior direction movement. No rotation is allowed during that period. The caver is removed with a stab incision so that there is no stitching is needed. A caver extractor, a small caver extractor is there, through which we can pull out the caver from the subcutaneous plate. You can see. Then I will show you some examples of the intra-articular fractures. This is a 46-year-old man with history of fall, severely comminuted intra-articular fracture. You can see the combination. The same man after fixation. You can see this reduction. You can see that the intra-articular fracture fragments here. This is the same man from day 1 to 1 year. You can see this fracture X-ray, pre-op, post-op, and also at 1 year. You can see at 1 year, there is a minimal stepping, that is less than 1 millimeter. There is no symptoms at all. The second row shows the range of movement before caver removal, that is before 6 weeks. And third row shows the range of movement at 1 year. These are the videos of the same person at first week. This is before caver removal. And this is after 1 week, 1 year, sorry. This is another case, that's 21-year-old bike racer with a bag of bones. He also came to me from Tamil Nadu. This is his pre-operative X-ray and also the post-operative X-ray. You can see the reduction and also the fixation. This is before caver removal, the same person. You can see this range of motion. This is from day 1 to 3 years of the left wrist. You can see this pre-op X-ray, post-op X-ray, and also X-ray before caver removal, after caver removal at 90 days, and at 1 year and 3 years. There is not even a single stepping is there. You can see this range of movement from the pictures also. It's the same person. You can see the video at 3 years. The important thing is that this racer returned to his racing after 1 year, and he had done bike racing from Kerala to Nepal after 1 year of my surgery. This is a 34-year-old lady with a history of fall. You can see this intra-articular fragment and severely comminuted also. The same person. After 1 month, the X-ray, you can see the severely combination, but the positions are maintained by the two triangles. There is no metaphyseal collapse. That's the main advantage of this fixation. The same person from day 1 to 1 year. You can see this X-ray at 1 year, up to 1 year also. The range of movement also is visible. After 1 year, the same person. You can see this range of motion. And also the X-ray is also shown there. No metaphyseal collapse at all. This is a 60-year-old man with a severely comminuted fracture, distal end of radius, intra-articular. That's the fracture fixation. That is from day 1 to 1 year. You can see this X-ray. There is a slight stepping. You can see here, but it is less than 1 millimeter. You can see this range of motion of the same person. This is a 39-year-old lady with a coronal split of the fracture. You can see that intra-articular coronal split there. That is, in that fixation, I will use additional cavage. That is more than 6 cavage I am using here. It is I have used 3 cavage from the lower edge for the fixation of the additional fragment. You can see this X-ray postoperative, how it is reduced. The same person from day 1 to 1 year. You can see the same person. The video you can see. This is a 74-year-old lady with a severely comminuted fragment, intra-articular. You can see this fracture. And the same lady, pre-op, post-op, and also X-ray at 1 year, and also her range of movement at 1 year. This is a 38-year-old male, CRIF done only after 2 weeks after the injury. You can see the severely comminuted fracture fragment, which was primarily treated by a POP slab, and check X-ray showed the displacement, and it was not in a good position. So I have done this after 2 weeks. You can see this X-ray after 3 months, this X-ray. And range of movement also after 3 months. This is another case, 44-year-old man with compound intra-articular fracture distal end of radius, which I have also put with this same technique. There is a severely comminuted pieces which are aligned into the normal position. These intra-articular fracture cases, the results were analyzed on the basis of the clinical scoring system of Green and O'Brien modified by CUNY on the basis of 4 criteria: pain, functional status, grip strength, and range of motion. Here, the study results, there are 108 cases of which I have put into 3 groups: Group 1, Group 2, Group 3. Group 1 is 18 to 45 years, and Group 2, 45 to 60, and Group 3, above 60. The number of cases were Group 1, 47, Group 2, 34, Group 3, 27. And the overall result of excellent and good result of the 47 of group 1, 43 had excellent plus good results, that is 91% results. And group 2 of the 34, 29 had excellent or good results, that is 85%. And group 3 of the 27, 22 had excellent or good results, that is 81%. The overall, from the 108 cases, 94 had a good and excellent results. That is 87% is the total study results. Here, detailed analysis of the criteria is paid. This criteria I have done at 6 months because I have compared these results with the conventional intra-articular fracture treatment with my close reduction and percutaneous peeling. This on pain analysis at 6 months shows 77% of cases have no pain and 20% have mild pain. That means 97% of the cases have no pain or only mild pain at 6 months. And only 3% have severe pain at 6 months, which was reduced to 1 after 1 year. Regarding the functional status, 54% of the cases return to their regular employment within 6 months, that is without any pain. And 43% of the cases return to their employment with some restriction. That means total 97% of the cases return to their original work, either without any pain or with mild difficulty. And 3 were unemployed. They were old people. Then regarding the grip strength analysis, that is 51% of the patients regained normal grip strength in 6 months, and 42% had more than 75% of the grip strength, and 6% had 50 to 75% grip strength, and only 1% had less than 50% of the grip strength. Regarding the range of movement, normal range of movement achieved within 6 months is 69%, and 29% achieved more than 75%, 75 to 99% range of movement achieved in 29% cases, and above 50 to 74 in 2% of cases. The advantages of my innovative pinning is that the stability is achieved by crossing of the cavers at 6 points with at least 2 cavers in each interfragmentary fixation. This is achieved by creating 2 triangles. That is, through the same direction, I am inserting 2 cavers in 2 different planes so that there will be that fracture fragments will be in a stable position. Even if there is pull by the muscles or ligaments, it will not move because it is in 2 planes and in slightly different angulation. The metaphyseal collapse is prevented by the role of the cavers, that is, which is similar to that of a steel scaffolding in cement concrete, because when I am creating these 2 triangles, which is in the ligamentotaxis position, that is, the ligamentotaxis ligament is stretched at the initial stage of the reduction, and the severely comminuted fragments, I have, by my milking technique, it is repositioned to the original stage, and fixing the cavers through the cortical outer cortex, that is the triangular shaped radial through the radius, and creating the triangle through the outer bone, so that it will not interfere with the forces. It will withstand against the forces. Then the 2 transverse veins passing through both the cortices of an index ulna act as a fulcrum. That is, whenever this ulnar head is intact, the stability is achieved through these 2 transverse veins passing from the ulnar head towards the radius styloid through the distal radioulnar joint. They were countering the rotational forces, and also they are stabilizing the distal radioulnar joint, thereby maintaining the negative ulnar variance also. The congruity of the RC joint is maintained by preventing the stepping due to metaphyseal collapse with the help of two transverse pins parallel to the articular surface and also two proximal pins directing towards the radiolunate facet. That's the dipenge area. This is the main advantage, main pillar for this intra-articular fractures, restraint of radius. The comparing result of the innovative pinning with the other surgical methods, the reflex sympathetic dystrophy is very, very low in innovative pinning when comparing with the external fixation and ORIF. Then full range of motion. Almost more than 75% of the patients achieved full range of motion within 3 months so that they can return to their normal work. But in other methods, it is not possible. Full grip strength, which is achieved in 6 months, that is also not possible with other methods. Because at 6 months, there is no implants at all. There is no implants in the patient inside the bone, or the patient range of movement will be achieved. As the caver is removed at 6 weeks, they can readily start the severe vigorous movements and it will be returned to the normal within 3 months. They can return to the original work within 3 to 6 months depending upon the type of work. And there is no tendon injury and nerve injury, and also it is a patient-friendly treatment also. Regarding the details of the complications of my surgical procedure, the pin migration is one of the most important complications because pin migration and pin loosening, these two things, this can happen. When we are using these smooth cavers, this can happen, and there's more chance is there when we are fixing this fracture in a severely osteoporotic bone. In that condition, we can avoid that thing by two methods. One is you can give a plaster slab in the postoperative period for 3 weeks. Second one is when you are putting these cavers, there will be, I have previously mentioned that there should be at least 2 cavers each in the interfragmentary fixation. Yes, that 2 cavers should be either diverging or converging, so that whatever be the pull over the fragment, it will not move. By that method of fixation, slightly altering the direction of the fixation, depending upon the osteoporosis, you can avoid this pin migration and pin loosening, and also by giving additional support with a plaster of Paris slab. Then residual deformity, this is also very less. This is also because of the first 2 things. Then skin necrosis. 9 cases out of the 108 cases, 9 cases have superficial skin necrosis. That is because of that the end of the caver, while I am putting it into the subcutaneous plane, if there is some length, increase in length, that can irritate to the skin and some skin necrosis. No deep infection at all in 108 cases. Then regarding the pin breaking, there are 2 cases it has happened. One of these cases, the 2 transverse, from the 2 transverse pin, 1 pin was loosened, that the patient was earlier removed the splint, and vigorous movement was there, and 1 pin loosened. So that at the end of 4 weeks, there was only 1 transverse pin, and which was not enough to withstand against the rotational force. So it has happened, and it was managed to remove that pieces from by over drilling from the ulnar head and pushing it towards the opposite side. Then reflex sympathetic dystrophy is also very, very minimal. That's of the 108 cases, only minimal. That's a type 1 in 5 cases. That was also in group 3, it was 3, and group 2, it was 2, and group 1, it was 1. They were all regained within 3 months. In osteoarthritis, radiological stages were noticed in 5 cases at the end of 3 years, but functionally there was not a problem at all. I don't know whether in future it will happen or not, but there was not much stepping. These are the slides of the complications in breaking. You can see that at the time of fixation, there were 2 transverse pins. 1 pin was loosened and it was removed, that pin was broken. First, I have removed that ulnar head piece, and after that, drilled through this and pushed that bone, the remaining part of the pin through the opposite side. This is a pin migration. You can see, even if there is pin migration happens, there won't be much happening because we are using two set of cavities, that is, two triangles are fixed. Even if there is one or two cavities are loosened, the position will not be lost. That's the main advantage of this two-plane fixation. This is a 57-year-old man where the pin migration happened, and also this fracture was, it's a proximal third was involved in this fracture. I have done only the same technique. That's why there was some malunion radiologically, but functionally there was nothing. But radiological malunion is there. The same person. You can see this function. On conclusion, the novel method of close reduction and ingenious percutaneous pinning is an effective patient-friendly surgical treatment for all types of intra-articular fracture distal end of radius by enabling them to early return to their original work with a very minimal complication. That is very, very important. Enabling the patients to return to their early work with very minimal complication. That is, altogether within 6 months, they can return to the original job. This is a AOS journal in which this intra-articular fracture distal end of radius was published in June 2020. Thank you. Thank you all.
Thank you very much, Dr. Anil. That was a very, very interesting presentation, and excellent videos that you have presented, and excellent clinical scenarios that you have presented. So, Dr. Salim, are you here?
Yeah. I have a few questions. Yes, sir. Sir, I saw all the cases. They were absolutely perfect, very well done, minimally invasive. With only help of percutaneous K-wires, fixation was achieved. Excellent hold was achieved. Quick mobilization after healing. Everything was perfect. Now, my one query is, sir, regarding severe osteoporotic fractures. In like wrist joint, as you know, it is very porotic at times, especially in the elderlies. So, had you had any complications in such cases using just K-wires for fixation in severe osteoporosis?
Severe osteoporotic cases, I am taking precautions. Just before I told, there are two, three things we have to keep in mind. That is, number one, during the fixation time, that the two cavities from the same direction. For example, from the radius styloid towards the proximal fragment, when we are putting two cavities, it should be either converging or diverging. That's from the radius styloid towards that, and also from the proximal fragment from the 3-point fixation. All the three cavities should be either diverging or converging, depending upon the combination. So that during the force of mechanism, when there is a pull of that fragment, that if it is in two directions, it won't move. That's the main thing we have to careful about the fixation in the osteoporotic bone. Number one. Number two, regarding the postoperative immobilization. That is, we should give plaster slab definitely, because usually we are giving for 3 weeks, but in severely osteoporotic, we should give it for either 4 weeks, or depending upon the severity, we can give another 1 week also. So that after the cavern removal at the time of 6 weeks, we need only 7 days of active exercises, so that we can prevent that pin migration. The pin migration is a main complication in severely osteoporotic bone. If we can keep this pin not migrating, that will not collapse. The principle of this is that the collapse will not happen because the 6 cavities are through the outer cortex, And in the picture also, in some of the pictures also, you can see at 4 weeks also, there are gaps are there, but the outer bones are healing, but inner there is some collapse. You can see this is some bone deficient area, but the bone as such do not collapse. This is similar to that of a steel scaffolding in cement concrete. That's why, sir. Anyway, I have also met with 3 complications of this malunion in severely that's above 60 years. That is one in 84, and I think it is one was in 76. And of these 327 cases, 3 cases had that complication.
Right. So you had a metaphyseal collapse in those cases?
No, there was not much metaphyseal collapse was there, because this initial period when I used to do this lab removal and exercises, when I started before 4 weeks, this was happened in 3 cases. After that, there was no such complication.
No, sir. Perfect, perfect, sir. Yes, Dr. Ashok, anything from your end?
So I wanted to ask, what is the rationale of cutting the K-wires below the skin and burying them?
Yeah, that is in the booklet and others for removing and also for preventing these migrations. They are saying that it's for preventing the migration, we can keep it outside. But the actual thing is what is happening. If you are keeping it outside the skin and we are advising the patient to move the active finger movement with much pressure, then the skin and subcutaneous tissue will move and the pin loosening, the hands of pin loosening will be there. One thing is that to avoid that, we can keep it into the subcutaneous plane. Second one, for those patients who are removing these splints and the active range of movement like writing and from the second day onwards they are doing, if it is kept in the subcutaneous plane, they can easily do the work. And the patient will not be feared about this cavities. Otherwise, if you are keeping them in the outside, they will not do the exercise as we are advising. Number 3, if the cavities are kept in the deep to that subcutaneous plane, there is a chance of migration towards the opposite side. Then the difficulty is that for removal at the time of removal, we have to give a small incision, little bit longer with the stitches, because the bone may be moved towards the bone, or if the bending end is small, it can sometimes go into the bone. So that, but anyway, we can remove it, because the end of the bone, there is a slight J-shaped curvature will be there. We can remove it. And the 4th one is that the radiocarpal joint. I am not putting this cavities from the as from the book says, from the dorsal side of the dorsal tubercular side, because the dorsiflexion will not be possible if you are keeping these wires outside this. So if you are putting these wires into the subcutaneous plane, the radiocarpal joint dorsiflexion and palmar flexion will be perfectly can be done by the patient. That's why, sir.
Okay. So another related questions to the same point. You're keeping the wire subcutaneous and asking the patient to move the wrist joint. So the skin moves and the wires are just below.
Yeah.
Do the patient report any discomfort or pain due to subcutaneous wires?
Yes, sir. Yes, sir. That's okay. Because if I showed the X-ray, there is a J-shaped curvature of that bone. If the end of that J is curvature is little bit longer, then the patient may complain that there is some pricking sensation, like a needle with a needle when we are pricking for this just like that thing, they will complain. So at the time of cutting that cavern, that we are giving deep pressure with the cavern bender towards the bone. You can see in the initial videos also I have shown that deep pressure is giving and bending, so that the bending point will be close to that cortical area, and also while cutting and giving this curved wire cutter, which is giving pressure towards the skin, so that the length of that J will be very minimal, that is up to 1 millimeter or 2 millimeter. In that case, there won't be much pricking pain or something like that.
Right. another question was, what are the contraindications for this particular technique? Have you not done or abandoned this technique in any case of distal end radius?
All cases I have done, sir. Those patients who are not willing for surgery only, I have accepted. All difficult cases I have done through this 108 cases includes. At that period, 2 years period, whatever cases came to me, even after 3 weeks, I have done it. From Gulf also, one case was after 3 weeks with external fixator and severe pain and severe edema came to me. I have done after 3 weeks and removed that external fixator and fixed it with the same this close reduction percutaneous spinning, and which was also, the result was comparatively good.
Okay. So in the same line, another question is, how long after the injury can you do this procedure? So say delayed presentation. So
yes, delayed presentation. Maximum delay I have done is 3 weeks.
Okay. So still you could get the reduction and maintain it.
Yeah, that one slide I have shown it also there.
Okay. So that's great. Yeah, Dr. Salim, you have any more questions?
No, I'm through. I'm through with my questions.
Okay.
Right.
So I think that was really excellent body of work and research that you have presented, Dr. Anil sir. And I hope we keep on developing these minimally invasive as well as economically viable solutions
Sir.
for our population. So recently, actually, I was writing something on the thing called clinical evidence versus economic evidence.
Yeah.
So most of our surgical techniques will be clinically equivalent or maybe just here and there, but economic evidence will play a major role, especially for countries like us, especially for hospitals like what you are working.
Yes.
So this has to also be stressed at all levels, and such kind of technique should be coming up, which balances the clinical as well as the economic evidence. So thank you very much for
Absolutely. Excellent work, sir. Excellent. Thank you, sir.
Yes, I will present by the rest of the cases, sample cases of the other region also I have shown, the tibial condyle and the tibia, and also that for this forearm, lower third fractures or others. For that cases also I will present later.
Sure, absolutely.
Sure, sir.
Thank you,
So
sir.
Thanks. I'll stop the meeting here, and thanks
Thank
the
you.
audience on OrthoTV very much for attending. Thank you very much.
Thank you, sir. Thanks a lot. Thank you.
Thank you.